sponsored by the number 3, right? 3 shocks, 3 rounds of CPR, maybe if you're old school, 3 milligrams of epi. And this is about 4 to 5% of all VF is refractory. And these are the people where you kind of don't want to pronounce them dead because it's a shockable rhythm, but they're just still in refractory VF. So what are we going to do? So prior to 2023, how many of you had started to think about pressing a couple defibrillators at the same time? Yeah, like we had started to hear some buzzwords of if we put some pads on, we could simultaneously press them at the same time. And this was like power. This was really cool. And we kind of had to ask ourselves, like, why does this even work? And really what you need to do is get such high currents that you annihilate every friggin' myocyte, right? And that's really the mindset. And the other mindset is you just need lots of vectors. And the more vectors you have, if you have here, maybe you get the whole heart. Maybe you get that posterior element. So this concept of more vectors and more current makes sense. And then, God bless Sheldon Cheskes, who should be up here and not me, basically the most important paper in resuscitation history. Like, I actually would say that I love this paper. I mean, this is, in my 21 years of practice, the most important resuscitation. Like, I'm not talking Procanamo or all those other trials of one doesn't work and one doesn't work. This is really important, really exciting stuff. So let's talk about it. It was a study that looked at 400 plus patients that were in refractory, right? So sponsored by number 3, they had a couple rounds, and they were randomized to either get standard defibrillation, kind of old school approach, vector change when they went from anterior lateral switch to anterior posterior, or they got a dual sequential defibrillation where they got hit at the same time. And they looked at this, and I think this is important to look at where you work. When they looked at the patients in the trial, 68% were witness, 58% had bystander CPR, about 8 minutes to the response, and about 10 minutes to first shock. Now, if you're in Europe where there's people in the rigs, that might be a reasonable thing. In the US, you might not get these metrics. If you're in rural Ontario, you might not have this metrics. Is this generalizable to you? This is a good question. To me in downtown Toronto, it might be in terms of response times. And they looked at a primary and secondary outcomes. And hallelujah, right? The primary outcome, the one thing we care about, is not survival, but survival to hospital discharge. Then you look at the double sequential group and you say, wow, although small numbers, 30% survived. And if you vector change them, 21% survived, and it's standard 13%. And those first 2 numbers reach statistical significance. This is fantastic, right? We have to all do this. And then they looked at termination of VF, and you can see double sequential, vector change. They seem to be better at terminating VF than what we've always done. And another secondary outcome, they started to crumble a little bit. They looked at ROSC, and they said, you know, DSED, significant, but vector change, you know, those confidence intervals, I don't know what the hell they mean, but they crossed 1, which means it's not that hopeful. And when they looked at modified Rankin score, so they looked at people and say, did they survive with excellent neurological recovery, while the group that got the double sequential did well and met significance, but the vector change didn't. So we kind of started to get this feeling that things are working well, especially for double sequential. And I think it came to the conclusion, yeah, I think you need to think about this.